This is a virtual conversation for our virtual audience. To our audience seated here, we'd request you to join us outside for a cup of coffee. At 7:30, you may join us for the book launch. Thank you.
Such a pleasure to engage with you because I just learn so much every time we speak. So let me start by really talking about your new book, The Song of the Cell. To me, it's almost like a sequel to your very amazing first book that I read, which was The Emperor of All Maladies, which was described as the history of oncology. And to me, this seems like the history of cell biology, because you really traced cell biology from its very discovery by Robert Hooke and Leeuwenhoek through their microscopic kind of discovery of the cell, right up to autologous cell therapy that we're also excited with today. So why don't you share with the audience why cells, why this tracing of cell biology, and why do people need to read your book? Because I think it's very important for you to explain why cell biology is so fascinating.
Well, Kiran, it's likewise always a pleasure to talk to you and learn from you. And welcome to the Tech Summit for everyone who's watching. The Song of the Cell was written, actually, there's a book in the middle called The Gene, An Intimate History. And it was written very purposefully because in some ways, the way to read these books is in a strange order. The gene comes first, the cell comes second, and the cell gone wrong, which is the cancer cell, comes third. The emperor of all maladies. So, in some ways, it's a mixed up order. But the reason behind learning about cells is that the cell, as you very well might know, is the smallest autonomous unit of life. Genes, there's been a lot of talk about genes and gene therapies. And of course, you and I, Kiran, have been now very deeply involved with gene therapies, bringing gene therapies in the context of cancer therapy to India through a company called Immunil. Genes are, of course, are extraordinarily important. They are the carriers of information. They are the carriers of heredity. They are the carriers of all the, let's say, the Morse code, as it were, that makes our cells function. But interestingly, DNA, the molecule that carries the gene, is a double helix, and it's become the icon of life. Every time you see life anywhere, the word life in a magazine or in an article, it's accompanied by a picture of DNA. But what's interesting is that DNA is actually lifeless. It has no life without the cell. It's a little bit like a score of music and the musician. The score is not music. It's the musician that makes that score into music. And in the same way, the cell enlivens DNA, enlivens our genome, enlivens our genes, so that they can now come into action, kick into action, and thereby create whatever we create. Our bodies, everything in our bodies has to do with cells or some action of cells. Every process that's going on in our bodies, digestion, metabolism, respiration, sentience, this conversation we're having is all a consequence of cell biology. And felt to me as if we needed a deeper understanding, not only of cell biology, which of course is the foundation, but also now the fact that we can manipulate cells with genes and thereby change their properties and are entering a new century of the cell, just like we had entered the century of the gene. It seemed to me that these ideas needed to be communicated to the public at a level that they could understand. What is cell therapy? Why is everyone talking about it? What is effective about it and what is not effective about it? But to understand all of that, we need to understand the cell. Why did COVID affect certain patients so severely while other patients were less affected? To understand that question, we need to understand, of course, the virus, but we also need to understand cell biology. Why did the vaccines work? Or why do some vaccines work and why do some vaccines not work as effectively? Once again, we need to understand cells and cell biology. So the very fundamental questions, not only in biology, but also in medicine, have to ultimately do with cells. And to understand them fully and correctly, we need to understand what cells do and how cells work. And that's the basis. I decided to write this book because of that reason, because it felt as if, people had written lots of books about genetics. I had, of course, written a book about cancer, but somehow in the middle had been left behind the most important element, the missing piece of the jigsaw puzzle, and that was the cell.
I must tell you, Sid, I really enjoyed reading your book. And in fact, I really believe everyone ought to read your book because you've just, talked about cells and cell biology in such a simple, effective way that just what you talked about right now is how people should look at cells. Why is it important to understand cells, cell differentiation? What makes a cancer cell? What is it that we need to do to, address cancer and fight cancer? And in that respect, I'd like to now shift gears to, another aspect of dealing with cells as the way you looked at it in your new company, Vor Biopharma. I remember you telling me about how you conceptualized this new company. And I'm sure the audience would be fascinated to understand in your very poetic lingo and your artistic lingo, what gave you that idea about starting Vor and how you looked at cancer and how you looked at creating Vor as a very new way of making sure that it's just the cancer cells that die and the healthy cells are spared. So why don't you tell the audience about Vor and how you basically conceptualized this whole new technology?
Well, Vor Biopharma was born in a very unusual way, which and the story, the story, Kiran, but I'll repeat it again. But let me give you the problem first. The problem is that cell therapies like T cells, you can weaponize or engineer T cells to make them kill particular other cells, like B cells. So T and B cells are two parts of the immune system. The T cell has a capacity to go and hunt out other cells. And if you arm it properly, if you weaponize it properly using gene therapy, you can kill many kinds of cells. In particular, you can kill B cell tumors, such as B lymphoblastic leukemia, BALL. In fact, the first story of the Song of the Cell is of a woman, young girl, 7 years old, who's cured of BALL using CAR T cell therapy, this weaponized T cell therapy. So this is a very powerful mode of killing cells. And it's very persistent, and it has proven out its mettle in many, many different cancers, mostly blood cancers, leukemias, lymphomas, and myelomas. And lots of people, including us, are trying to extend this into solid tumors as well. So the problem with these weaponized T cells is that they don't only kill the cancer cell. They also kill the normal cells that resemble the cancer cells. So in the case of Emily Whitehead, this young girl who was treated in Pennsylvania by Carl June, one of our colleagues, with CAR T cell therapy, the T cells killed all the malignant B cells. So they killed all the tumor, the lymphoma, but they also killed her normal B cells. And that's just part of the process. There's the weaponization of the T cells doesn't distinguish one from the other. Now, it turns out that just by a coincidence and chance, human beings can live without normal B cells. We evolved so that we can live without normal B cells. It's not the perfect situation because we need some medicines to help us. We need intravenous immunoglobulin, so infusions of a medicine to help us. But that's the case with B cells. Now you come to another cancer. Called another kind of leukemia called acute myeloid leukemia, AML. Now, again, you can train T cells to kill AML, the cancer cells, but now you run into a problem because unlike in the case of Emily Whitehead, the normal cells, if you kill the normal cells, you can't live. So the normal cell toxicity is so high that you can no longer live. It's not compatible with life. And this was almost like a glass ceiling or a medical ceiling that all of us faced who treat acute myeloid leukemia and similar diseases, which have to do with the myeloid compartment of cells. So I've been racking my brains about how to address this toxicity problem, because of course this problem is a very big problem, because if you don't address it, you aren't able to kill the cancer. And AML is a very deadly disease. You can do a bone marrow transplant, but usually in last-ditch cases. But really, the mortality is extraordinarily high. It's a very deadly disease. So I thought to myself, I was making drawings in Mexico with my two daughters, and you could make two kinds of drawings, as you know. You could make a drawing with a black pencil on a white paper, which is the standard kind of drawing. But that morning we were making opposite drawings. So we were making using a white pencil on black paper. And I thought to myself, wait a second, for all this time, for centuries, we've thought of the cancer cell as the black drawing on white paper. But what if we inverted that whole situation, inverted the paradigm, and thought about the cancer cell in an inverted way? So we would change the normal cells using genetic engineering. Instead of changing the cancer cells, we would change the normal cells and then direct the therapy. Now, all of a sudden, the cancer stands out and the normal cells become resistant or immune to the therapy that we're giving. And in fact, using techniques of engineering, we can do exactly that. We can take normal cells and make them unique. We can take away something from them, an antigen or an enzyme. We can take away from the normal cell. And it was that drawing that really inspired me to start saying, well, what if we could do this in a human being? We would take away some component, some feature of the normal cell, and thereby expose the cancer cell like a sore thumb. It all would suddenly stick out. Its flags would stick out. And now once you have the flags of the cancer cells stick out in this inverted paradigm, in which you're converting not the cancer cell, but the normal cells.
And where the normal cells wouldn't have those flags.
Exactly. The normal cells don't have those flags. Only the cancer cells have those flags. And so now
maybe you should tell the audience that you would actually then transplant those normal cells into bone marrow and get the patient just to produce those normal cells as very unique cells.
That's right. So, normal cells will be produced exactly as Kiran is saying, as very unique cells, and the cancer cells will uniquely bear the flag. And now that you have the flag, you can use the immune system or any other system, but the immune system primarily to kill the normal cells. So it was a I would say a
chemo targeting agent as well.
That's correct. Yeah, that's correct. So it's a somewhat mad approach, I would say, but in fact, in animal models and hopefully in humans very soon, we'll see the first examples of genetically altered bone marrow such that it exposes the vulnerabilities of a cancer cell. The cancer cell with its flag, well, the normal cells have now lowered their flag, and now you can attack it with this deadly disease with T-cell therapy.
And I understand that the US FDA has given you a kind of a fast track designation. And
that's right. So we got the very rare fast track designation because we showed them preliminary data that it was safe. They were very impressed and has given us fast track designation. It's a very rare, as you know, it's a very rare designation given only to therapies that meet a certain criteria that are over and beyond what everyone else is doing. So it allows you to essentially communicate with the FDA in a very rapid basis, on an hour-to-hour basis. If you can demonstrate that this is efficacious, they will move you fast track through the process.
Wonderful. I think we ought to now share with the audience what we discussed about CAR T therapies for India and how we basically co-founded Immunil as a pioneering CAR T company. Because I remember it started with a conversation that you and I had in New York, where you basically said, why is it that India is nowhere on the map of the CAR T world? And you also mentioned that, look, China is doing so much, many other parts of the world is doing so much, and India ought to be there doing something. So why don't you share with the audience
Yeah,
the discussion we
the
had?
first conversation was in Boston, and the moral of the story is if Kiran invites you to dinner in Boston, go to dinner. And so Kiran and a group of other friends were meeting in Boston. I happened to be in Boston. I didn't know Kiran very well. I happened to be in Boston. I was seated next to Kiran, and I turned to her as she was then coming to New York. So we were carried on that conversation in New York. But the question I turned to her and I said, listen, we can send a rocket to the moon. We obviously build incredible technologies, supply software to the world. And yet, one of the major modes of cancer therapy, CAR T cells, and perhaps more broadly speaking, Kiran, gene therapies, very broadly speaking, are really unavailable in India where the unmet need is huge. I will tell you very soon what the nature of the unmet need is. But in our company, we routinely, I would say, get on a daily basis requests to treat patients like Emily Whitehead, the girl that I profiled in my book. We get requests for treatment of these relapse refractory patients. Remember, these are often ALL is a childhood disease. It is one of the diseases that responds extremely well to CAR T therapy. And it's a dangerous therapy, so you have to be very careful. There will certainly be dangers associated with the therapy. But nonetheless, like all chemotherapies, it can be very successful. And for patients with relapsed refractory ALL, that is ALL that is no longer responding to standard chemo, there's really no other option. They can go for a bone marrow transplant, but that bone marrow transplant is very toxic. So just put yourself in the shoes of that 10-year-old boy or the 10-year-old girl or a 7-year-old girl who has ALL, could not respond to standard chemotherapy, and has now no options left, and is looking down the abyss of death. And I said to Kiran, we should be if we can develop all these technologies, then why can't we develop T-cell technologies? What is it? It's not like making gold out of lead. This is just thoughtful labor, the assemblage of very smart teams, the assemblage of very good technology and technologists, and the passion that I think is the most important piece to bring a novel therapy to India. And right there and then in New York, we said, let's just do it. Let's just try. And I should really commend Kiran herself, but also the team that she assembled around herself of people who were totally dedicated to this. And I can tell you, it really almost brings me to tears, Kiran, the amount of dedication, because right through COVID, in the middle of the worst conditions that anyone could face, we didn't have any, thankfully, we didn't have any complications or anyone who got really sick. But right through COVID, these workers in masks and in proper hazmat gear and so forth built this facility, which is now fully operational, has dosed several patients, and will continue to dose patients on India's first phase 2B trial to determine whether CAR T cells can be safely and effectively delivered in India, and exactly what the safety and effective parameters are. So and
also you should also mention that one of our objectives was to provide affordable access to this very expensive therapy.
Right. So just to give you a sense of the cost of the therapy, in the United States, these CAR T cells are cost around $400,000 to $500,000. That is coming on top of about $500,000 or $600,000 of chemotherapy that can last 2 years. So you can imagine you're again a child of 7, diagnosed. 2 years will be spent on chemotherapy, 2 years of your valuable life, and then followed by this frantic hunt for various therapies. So we thought that we would slash the cost enormously as much as we could, and we're still going through the process using substantial Indian engineering to try to see how we can slash the costs so that we can make it affordable to India. Now, just to be very clear, there are some fundamental expenses associated with this therapy. The fundamental expenses are that you have to use extraordinarily very high expensive equipment. You have to use very sterile facilities. You have to use technologists who can release these. These are dangerous therapies. There will certainly be people who don't respond or who have very severe responses to the therapy itself. But all of this said, I mean, these are people with no other option, and we are delivering them potential cures. So I again think that this is another advantage that India has, that we can provide these therapies at a fraction of a cost compared to the United States, where they become really unaffordable. And Kiran, back to you in some ways, maybe I'll ask you the question. I mean, this was also your vision when you started Biocon. Is not in cell therapy, in the cell therapy arena, but in other therapeutics. So tell us about the motivation of starting Biocon.
Yeah, so of course, I started Biocon in 1978 not as a biopharmaceutical company, but as an enzymes company, which of course I quickly pivoted 20 years ahead into a biopharmaceutical company. And I think the driving purpose for me was, again, what you just said. I just felt that India had to avail and access these very important biologic drugs. And most of these drugs were beyond the reach of even well-to-do people in India. And I can tell you that, my best friend who died of cancer, breast cancer, many years ago, just could not afford even a simple drug like Herceptin. It was way too expensive for someone like her, who was a very well-to-do professional. She had to sell her property to really afford this particular drug. And I thought, my God, I've got to do something about this. So it was with that in mind, and of course the fact that insulins were such a huge need for the country because of this enormous diabetes burden that we have. And I realized that we were importing all our recombinant human insulin. I thought, I've got to do something about this. So based on that, of course, I started developing, monoclonal antibodies in the form of biosimilars. I also started developing novel antibodies for some of the cancers which are very prevalent in India, like, head and neck cancers. And then, of course, I also developed insulins, just basically to really address this huge cost barrier that we had of affording these kind of life-saving and essential drugs. So I'm really pleased that, over this past decade or so, we've actually managed to disrupt the pricing of these very expensive drugs. I think we made it extremely accessible and affordable to any and every patient, not just in India, but in the developing world. And I think technology has a huge role to play in these kind of efforts. And I think that's what also excited me about the CAR T therapies that we were developing, because I felt that we are in a humanitarian business. And I think if we don't serve patients who need them, I think we are not doing justice to science. And that's what it's all about. So that's what really drives me in terms of my sense of purpose. I'm sure that's what drives you as well, Sid. Knowing what you've been doing all these years and sharing a lot of these very common interest that we have in terms of disrupting and serving patients anywhere and everywhere is what keeps us both very energized and engaged and, focused on delivering science to society. So I think that's what it's all about.
I agree completely, and I think it's very important to keep that mission, the sense of purpose. I mean, when I come to visit Immunil in Bangalore, this is the CAR T company, I'm amazed every time at the sense of mission and purpose that the people who are employed in Immunil have. They come all the way every day, and they know at the other end of the whatever process that they're doing is a 10-year-old boy, 7-year-old girl, 20-year-old woman who is waiting for these new therapy and really has no other option and no other chance. And so I'm enormously impressed by their dedication and purpose, and I think it's one of those things. And secondly, I'm really frankly impressed by the pace of technology in India. I mean, the level of conversations that we have as we develop not just one CAR T, but a whole suite of CAR Ts, about 6 or 7 of them, some of them which will be proprietary to us, invented completely by India, by Indians for the world market, will be absolutely revolutionary. I mean, there is a fantasy that technology always moves from the sort of global north to the global south, or that rich countries can make the technologies, and poor countries have to go around sort of begging for those technologies. I think both you and I are disruptors in the manner that we want to also give back. We want to create technologies that we make and send them back. And of course, this is already happening in other industries, the software industry notably among them. But why not in biotech? In biotech, why not do what we have been calling reverse tech transfer back into Europe and to the United States and to Japan and China and other places where they have highly technologically adept systems. But of course, we also can certainly invent new biotechnologies, put them on trial here for the benefit of patients, and if successful, move them to other countries.
But in that same vein, Sid, you and I have often discussed as to why India is not innovative enough. We know that we have a huge diverse disease burden. We have a huge clinical ecosystem. I think the kind of, the diversity of patients that we see in a country like India and the number of patients we see in every medical center is just mind-boggling. And yet, we often discuss that why aren't we using these opportunities for translational research in a bigger way? If you were to basically share your ideas with, say, the Department of Biotechnology or the Department of Science and Technology, what kind of policy measures do you think we should really focus on to get this whole energy and this innovation ecosystem going in a way that we can actually come up with, really new ideas to disrupt and address unmet needs?
Well, I'll certainly come back to you with the same question, but on my end, what we found is that the Department of Biotechnology, the DCGI, the ICMR have been very cooperative, have been champions in some ways. But of course, like all departments that have to do with human trials, have to be very sensitive and thoughtful about the nature of the trial and what is happening next. Now, all of that said, I think that more could be done here in the United States, but certainly could be done in India. I'll just give you a couple of examples. India still lacks a bone marrow registry. That's a big problem because most countries now have bone marrow registries. The European one is particularly good. The German one is particularly good. We don't have one. There are still pockets where, when you go to the hospital, I think less than 1%, I can't quote you the exact number, but less than 1% of patients are on clinical trials. The infrastructure to run a clinical trial, you need infrastructure. You need an entity that will record the data safely, anonymously, maintain the privacy of the patients, but also report out accurately the quality and the effectiveness of the clinical trial. That ecosystem we have to build from scratch in India because it doesn't exist. So there are many pieces of infrastructural ecosystem I think that we need to build in India. And what's astonishing is again the diversity and the number, the amount, the demand for these kinds of therapies is enormous because there are so many patients. India is a massive country, and there's a huge unmet need for virtually any disease. And what's interesting is that that's not just restricted to, you used to think about India as a site to run trials for infectious disease. But as the Indian demographic has changed, the diseases that men and women and children in our country are falling prey to are diseases that overlap with the diseases across the world. Diabetes, hypertension, obviously cancer, autoimmune diseases, heart disease of any kind. And the numbers are so great that we could be running, it's not an underestimate, thousands of clinical trials every day, and giving information back not only for our own patients, not only for their own children, but also for the world. And the fact that we haven't been able to do so really demonstrates that the ecosystem of running clinical trials, doing biotechnology, which then will feed into the clinical trials, creating new inventions that will feed into the clinical trials, is not yet fully at the pace that it should be or could be given the large unmet need that we have in India.
Yeah, I agree with you, Sid. And from my point of view, I've always believed that for a country like ours, we need to invest much more in innovative research. And I think one of the challenges that we have is that we are in a comfort zone of really focusing on re-engineering what has already been discovered. We are very good at developing generics or biosimilars, but these are discoveries that have been made elsewhere, molecules that have been developed elsewhere, and all that we're doing is using our innovative skills to just basically replicate these molecules. And I personally believe that we really need to start investing in deep science, deep research, come out with very innovative products, which I think will only happen if we start incentivizing research. And I've been a big proponent of research-linked incentives in the same vein as production-linked incentives. If you don't incentivize, big Indian pharma to really invest in research and innovation, I think we are actually losing a huge advantage that we have in terms of our scientific talent, our research talent, because we are not kind of incentivizing them and rewarding them to think in a very different way. So I personally hope that the government actually starts coming out with a very effective research-linked incentive policy that will then finally see people taking greater risk. Because today I think Indian industry and Indian investors are very risk averse. They do not want to invest in any unknown research or sort of unpredictable outcomes of research. And I think they need to understand that research is experimental, research is unpredictable. But when things happen, it is absolutely transformational. And, they address these unmet needs, like you said, in a fantastic way. So I really believe that, you have to start directing people and researchers and scientists to experiment more, to question more, to really, really do things that you just talked about. Your whole concept of war biopharma. I mean, you challenged something and you came up with something quite extraordinary. And I think there are many of those opportunities for us in India to explore and invent and experiment with. So I really hope that we see policymakers really providing some financial incentive for people to start innovating through experiment and inventiveness. So I think we've kind of really had a very overarching conversation on a very fascinating area, which of course started with your interest and your understanding of cell biology. But maybe I'll just ask you to give me some concluding remarks on where do you think we should be focused on as a country, as someone who is so invested in cancer research. What do you think we should be doing in India? Of course, cell therapy is something that we are both very focused on. But I'd just love to have some closing remarks from you.
So thank you, Kiran. So I think the important thing, of course, is that all cancer research or cancer treatment and prevention is built on a pyramid, and we need to concentrate on the pyramid. The bottom of the pyramid, which is the base layer, is prevention. And I think we're not doing enough on cancer prevention. We know that there are major preventable carcinogens that are still going unnoticed, really, cigarette smoking being one of them. The other one, of course, being, among other ones, being appropriate vaccination for human papillomavirus, which is a major cause for cervical cancer as well as head and neck cancer, very common in India. And a reduction in diabetes or diabetes and the combination of diabetes and obesity, which is actually becoming a mini epidemic among certain fractions of people in India. So that, along with maintenance of adequate nutrition and adequate health services, is the bottom of prevention. The second layer, which is early detection, includes things like mammography, colonoscopy, sigmoidoscopy, fecal occult blood testing, frequent examination of the oropharynx and things like that. Really health services that detect cancer in its earliest phases and hopefully eliminate cancer. So that would be the second prong. And the third prong is treatment. That's the narrowest prong. That's the top of the pyramid. And there it involves novel forms of therapy as well as existing forms of therapy. And I should not minimize the role of palliative care, which has really been, I think, a somewhat missing element in our pyramid of cancer care in India. You still, patients are dying in pain when they should not be, because we have very good pain medicines and palliative care available in the world. We just are not using them effectively in India. So I think the pyramid needs to be built from ground up. I think in the United States, a National Cancer Commission could do a lot. We certainly have the scientists to be able to sort of create the infrastructure and prop up the infrastructure to create this pyramid. And there's research to be done on every level. It's not like you only do research in the treatment or in the prevention arm or in the early detection arm. Each arm of this leads to several very important research questions, including some behavioral research that lies outside what we call traditional biotech research. I've tried to make two pleas. One, in addition to all of this, is to really appoint a group of people, whether you call it a commission or whatever you call it, to ensure that as the pharmaceutical industry moves forward, like you have, Kiran, that there remains within the pharmaceutical industry an incentivized structure such that some part of that pharmaceutical company is carved out to do research only. And by a combination of incentives and audits, we confirm that part is truly doing innovative research and is not just spending the money, on various other activities. So that would be one very important thing, is to mandate that some fraction of a pharmaceutical company that is established or has a certain level of establishment in India carve out a place so that some innovative research, something new is being made. And number two, do this outside just the pharma universe. In other words, very broadly speaking, as you're saying, provide important incentives for the discovery of new biological medicines and other medicines, such that once they have been discovered, they don't get lost in the process, and that they have some mechanism by which they are supported at the state and the federal level, and that mechanism should be formalized rather than being informal, so that there is mentorship, there is guidance, there is very clear communication between this new discovery or discoverers and the DCGI, the ICMR, and other regular DBT and other regulatory authorities, such that they can mentor the development of this medicine. I mean, when we started WAR, we were 4 people, right? And now we're 150. So, and that was because we were able to take part or assess or really absorb the ecosystem that had been laid down for decades in the United States to mentor the development of a new medicine, making sure it was safe because it was effective, but we would really be able to assess that ecosystem. And again, to return to the song of the cell, I tell the story of Banting and Best discovering insulin in a little lab in Toronto. I mean, big University of Toronto, but in a little lab in the University of Toronto in the middle of the hot summer. And they suddenly find that if they inject this substance into a boy who's almost dying, comatose from diabetic ketoacidosis, the boy comes alive all of a sudden, that one injection. This was in 1921. We are now in 2022, celebrating almost the 100th anniversary of the discovery of insulin. And yet in this country, at least, we still pay hundreds of dollars for even a month's supply of insulin, and
which I'm trying to disrupt.
Exactly. So what I would say is that novel technologies don't just involve making new products; they also involve making new processes. These you and I have spent a lot of time thinking through process development, and so there's a whole range of stories that I could tell, stories that are in the book, in which time after time, you see the discovery of something absolutely brilliant and new, but then it requires a whole ecosystem, a village, as it were, to prop it up. And I think that the more we make of that in India, the more we will become the biotech powerhouses and the medical tech powerhouses that India can be and deserves to be. And as I said, congratulations to you on Biocon, and now I suppose to the really dedicated workers who brought CAR-T therapies to India.
And in that, in the concluding statement, I'd also like to say that we have something else that we can actually add to this power statement, and that is digital technologies, because I think AI and data science and all the wonders of digital technologies also have a lot to contribute to the way forward. So with that, Siddhartha Mukherjee, thank you so much. This has been a wonderful conversation, fireside chat, and I'm sure the audience must have enjoyed every word that you said. Thank you.
Thank you very much, and I look forward to my visit in January.
Thank you.